It's the 19th of November, 2021. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush with RheumNow. I'm joined by Kaleb Michaud from the University of Nebraska Medical Center, and we're going to discuss resistance and change. But first, you've seen this sort of scenario. Patient comes in, they're not doing well. You figure it's time to write a new prescription. You give them the prescription only to find out later on they didn't fill it. They were concerned, not really ready, and they didn't change, and you're not quite sure why. So on this podcast, we're going to talk about resistance, unwillingness to change, and what this means to practice. So Kaleb, thank you for joining me. Kaleb Michaud is from the University of Nebraska Medical Center. He is the principal investigator in the Forward National Data Bank for Rheumatic Diseases study. It's been a longitudinal study that started by Fred Wolf, and Kaleb's been running it for a number of years now.
23.
Kaleb, how many?
23 years now.
Oh, well, so you're a rookie. Pretty
Yes.
good. Kaleb, thank you for coming on and talking about this really important abstract we're going to talk about. First, tell the audience about the Forward Registry.
The Forward Data Bank Forward is the new name for the NDB. It is a longitudinal observational registry. We've been enrolling folks since 1998. Basically, anyone who's seen a rheumatologist in a rheumatology office is probably going to be eligible. We're looking for anyone with a rheumatic disease, and they fill out questionnaires every 6 months, twice a year. So this is sort of the model that started with lots of national registries back in the 90s, hence the name National Data Bank at the time. So we renamed it Forward just a few years ago, sort of make it more patient friendly. And we have a magazine that goes out to all of our participants. But since then, we've got a few hundred papers, and we are a nonprofit that tries to provide our data to researchers and folks who have interesting questions along the way. We're constantly asking new things as well as people think of them.
Yeah, it's really, it's a wealth of information. You know, any of the papers that have come out of that have always been very practical and very useful. We're going to talk today about your abstract at ACR 2021-1158, entitled Resistance of Patients with Rheumatoid Arthritis to Changing Therapy, a 15-year follow-up by Kaleb and coworkers from the University of Nebraska and this Forward study. What you did back in 2006 with Fred was you inserted 9 questions in your usual 6-month survey about patient satisfaction to treatments that they were taking and their preferences, and specifically the idea of change and their willingness to change therapy. And here you are, some 15 years later, asking the same question. I'm just going to go cut right to the chase. The bottom line of this study was that from 2006 to 2021, the patient number on unwillingness to change did drop from 64% in 2006 to 51% in 2021, but there were 442 patients in this cohort who answered both surveys, and yet their unwillingness to change really didn't change. So have patients changed over time or not?
Well, we have found that they have changed in some ways, some important ways. So let me back up a little bit, because that 2006 study that Fred and I did, what drove us to ask those questions were that we had so many patients who had poor outcome scores, poor HAC, pain, everything, yet they were still on their CSD marks. They weren't sort of doing the treat to target and taking advantage of all the new therapies that were available. And so we're trying to figure out why. And in the end, sort of the thesis of that is that people were afraid of getting worse. And they all had experiences of being worse and side effects or something else. And it's just so that they were okay being at moderate levels because it was sort of a day-to-day manageable scenario versus they could imagine a place where it could be much worse than that. And the idea, when you have change in therapies, it's often associated with some sort of change in disease activity. You're right. So we learned to sort of, let's see what happens now, considering there's a whole bunch more therapies than there were back then.
Right.
And now we're sort of reverting back to orals instead of the injections and infusions, which we thought were the biggest barriers to trying something new. And we didn't see as much change as we expected. The biggest areas of change is that cost wasn't, and insurance was not as much of an issue as it was back then. Now there's two things there that I see to highlight. One is that the pharmaceutical companies have done a great job making sure that if you're prescribed the drug, that you're going to get it, even if you can't afford it at some level. And that wasn't necessarily there 20 years ago. But second, is probably a sign of the folks who are still participating are more likely to have good coverage as well. And we've sort of seen that as well, a little bit of the participation bias. But the areas that we expected to change, that the people who would be more amenable to trying something new didn't. And why aren't more folks maybe moving to something else, or if they're still not in a great place where you'd want them to be? And a lot of the same reasons are still showing up.
Yeah, I would think, well, back then we had an issue of fear and risk based on the newness of the drugs, and they said they were doing IVs all of a sudden. And now the fear and risk equation seems to have changed, but it still seems to be equally present. Here, fear and risk is driven by direct-to-consumer advertising, and everybody sees all this reminders of all the bad things that can happen all the time. But again, I was surprised to see that risk of adverse events has not changed as far as its importance here. It's still important. It's one of the three big things you point out.
Yeah, and if you've ever had a side effect to a drug, you're much more susceptible to be, less risk averse. I mean, more risk averse, I guess, in this case.
Mm-hmm.
And I think that's still driving a lot of this, because what you see is if someone is, for example, switched to a TNF, and initially they were successful, they did well, but then over time you sort of see the gradual, like, well, they're not under the control that you'd like to be. You want to do a different MOA, mechanism of activation for them. What happens is sometimes they're like, well, why don't we try another TNF, because I didn't have a bad reaction to it at the beginning, so maybe another one would do it, as opposed to trying something that has a completely different approach to it. And that's sort of that risk averseness that comes into play oftentimes.
So the unwillingness to change number did go down from 64 to 51% in 15 years. Do you have a feel for why?
Well, one of the things that came up at the ACR poster, which was very good because we did the analysis in the last week, was, so how much is disease activity? And so what we did is I split up the using the PAS-2 patient activity scale, and remission, low activity to moderate and severe. And if you do a binary split there, which is in the 2021, when we asked this in January of this year, we're about median time point, about halfway and halfway. It's really driven by that. It's really the disease activity there. And the people who are afraid of getting worse are the people who are doing well. Like, they don't want to get worse. They're under control. So they're more resistant, which is good, which is where you want it to be. But I can jump to the end where I think things are going to go, because another paper that I'm working on is looking at adherence of medication, and the spoiler alert, it's really being driven by patient global, what the patient thinks, how they're doing. So I just said this earlier in our didactics at Nebraska. It was like, physician global drives prescription changes, as it should, because if you see somebody doing worse, you're going to put it in your global assessment. It's the patient global that drives their adherence to the drugs that they're on, and willingness is maybe to try something else as well.
So if I'm doing well, does that mean I'm doing well enough to stop, or I'm doing well and I don't want to screw it up and I'm going to keep going?
You don't want to screw it up. You don't want to make a change, right? But I mean, there's clearly other things that lead to that. There's a whole aspect of socioeconomic status and education and other aspects there as well.
Interesting. So back in 2006, you guys wrote that like patients were like 70+% satisfied with where they were, and
even if they had poor scores. Exactly.
Yeah, and then when you looked at that 70% who were satisfied, that a high number of them had moderate, over 71% had
right.
moderate or worse disease activity. It seems then that over time that patients have taken the option of getting better, so they do have better disease activity, but still some are worried about change. And maybe is it for different reasons? Now they're worried about change because they're doing so well. Before they were worried about change because they weren't.
It's all about adaptation. adaptation at some level, right? If like you have a certain level of disability and pain that you live with, but you're able to either get a job that you can do with that or have a sort of quality of life that you're used to. And then you know that when things are bad, you can't do that. So you don't want to trigger that, whatever will cause those flares, or so you can't have what you sort of gotten used to. And it's something what we see in older age groups as well, which is often happen in this cohort too. With older age, the pain levels go down. It's not that they're actually experiencing less pain, it's sort of the adaptation to it. So it's a little bit of everything, and this is far from being done. We're still doing the analysis on this, but just sort of some early messaging from it at this point.
So the three things that did hold true back in 2006 and today was patients were unwilling to change if they were satisfied with RA's good control, concern about potential risks, and what the doctor preferred as far as their treatment, which means that they are listening to some extent to the doctors. Are there any others that sort of stood out? I know you asked a lot of different questions in there about potential reasons, and I again, none of them jump off the page at me.
Yeah, and in the end, it's sort of the disease activity, the patient global were big, the education, and also, I mean, we've been using some of these other scales. I always know the acronym, beliefs and medication questionnaires and things like that. And it seems to be a very important tool before prescription. But once you're actually taking something new and you're on it for a little bit, it sort of goes out the window. Then everything changes back to sort of a new normal. So it's really sort of that risk averseness that goes up to, okay, what is it going to take for me to try to something new? Some people are like, they switch all the time, and sort of gotten used to that, especially since there are so many new therapies available. And for the most part, those tend to be folks who are not under control, who are on glucocorticoid steroids, and they're still trying to find sort of a happy place. But for those who have sort of been on one therapy for a few years at a time, that resistance to trying something new, it's a big deal. And it definitely requires multiple conversations and enough flares along the way. So we're seeing lots of things around there. But another part that comes up that it's always been the case is what's going to be reimbursable, and that's sort of out of their control.
So in back in 2006, you wrote that other things, non-medical factors, really weren't big in there. Administrative issues and how you take the drug and inconvenience, that those really didn't pan out very much. You still think that that's true?
It always affects the continuation, and whether or not you get it to begin with. But rarely do you get prescribed and start something that gets taken away from you. But now that we have biosimilars and lots of other things coming along the way, those are definitely issues that come up, but not that weren't as present in 2006.
So I'm a little concerned. I like how this has evolved. I like your understanding of this. I'm a little concerned on applicability in that, is it possible that the last survey of 1,600 patients, you skewed this by having really good patients, people who know what they're doing, and they bought into the game, and they're not. So how would this look if you were looking at people who are new to the medical clinic and their diagnoses in the first year?
That is a great question, and it is skewed that way. I mean, and think about it, these are people who've been participating in Forward Data Bank for a few years now, because we haven't been able to recruit much during the pandemic, and they're answering the question in the middle of the pandemic, and so that both contributes to it. They're older in general, and they definitely have more experience with more drugs, but that also means they've had more experience with side effects. So this is not your run-of-the-mill newly diagnosed RA patients, and that somebody who's newly diagnosed, the idea of going quickly to a biologic might be anathema, to them, and so we're not getting that in here. Whereas having other therapies who are considerably strong that are oral once a day seems like, okay, that seems a little more reasonable.
So the issue of time factors into this. So there's the book by Malcolm Gladwell, Tipping Point, showing that you need 10 years to change or more to change behaviors, even in the face of strong data. And then there's the Ellsberg paradox, which Daniel Ellsberg talked about decisions being driven by a version of ambiguity. You'd rather stick with the odds that you know as opposed to the unknown odds of potentially getting better, but they're unknown odds. So you stick with where you are as opposed to maybe taking a risk. So ambiguity of change is really, really worrisome. And then, of course, Michaud and Wolf in their 2006 paper, published 2007, says it's better to dance with the devil you know as opposed to the devil you don't.
And that's what the patients say.
Right. And shouldn't though time have changed this problem? And did time change the equation here for you in your 15-year follow-up?
So one thing this study doesn't answer that is how many of these participants actually know what their disease activity is? Like, where is it? And like, what are their physicians at? And I think it's a very different conversation if they can say, well, I'm now at this medium or high disease activity level and I need to do something different because this is not where I want to be, versus I'm okay with this, even though it's not where my doctor wants me to be. And that really comes back to the conversation, the communication of what are our goals? And if, as physician side is like, we want you in low. We want you low disease activity because all these other bad things happen when you're anything above it. But the patient is like, well, I'm kind of okay where I'm at, this control, where so it really comes back to that. It's one thing I see, and the second is like you said before, is the overall willingness to change. I mean, I know a lot of people who feel like if they don't get an injection at this point, they're not getting real therapy because they're so now trained to do that. Right. So if there's not the pain and the feeling of something's working, something's happening in me, versus others, you're like, keep those away. Wouldn't even think about starting.
I almost get the sense that patients are forced to play the game we make them play, meaning that when you look at patient perceptions of their status and outcome, they're different than doctors. Doctors are driven by swollen joints, and patients are driven by pain and fatigue and lifestyle issues that doctors may not really factor into. But yet patients are dependent upon the doctor for the next treatment change, or for the plan of therapy, or for the prescription. So when a doctor says you're doing great, you're in remission, even though they're okay, all right, I'll take this because one, it's the game I'm playing, and two, I don't know I want to change.
That's exactly right. I mean, this is not, I don't have much more to add to that. That's exactly right. We have different goals at different times, and you can only measure so much from the patients.
Are you in the parallel thing that you're doing with adherence? Is it the same data set? Is it going to be tied to this analysis, or it's just going to be a sort of a parallel analysis?
It's parallel. It was a completely different study, taking a look at adherence, following up on our methotrexate adherence, and it just screams at me to sort of like patients. First of all, if they take things in the morning, they're more likely to be adherent. But also, if their patient global is better, they're more likely to be adherent. So.
Do you think you have any advice for clinicians out there who time to time struggle with this, patients who are unwilling to change? What can be gleaned from these two separate studies, 15 years apart, that could make us better at? I mean, our biggest struggle that we don't really address is we're not really in the business of making patients into good patients. We think if they just listen to everything I say that they'll be a good patient, but it's so much more than that. So
I feel like your shirt sort of gets to the struggle we're having, because you can tell your patient to get vaccinated. It doesn't mean they're going to get vaccinated. And it's not so different, right? He's like, okay, well, I think you should take this Medicaid, this DMARD, you should take this, here's the prescription. And then what happens is sort of a black box. You're like, well, I provided you with my role as the physician, as opposed to I'm here to help you help yourself. And here's the information that you need. And I want to answer your questions. But, because it's not your job to sort of be making sure that they take the pills each day. It's, at some level, you have to get some sort of sense that they're doing it for you to actually feel like you have a relationship that you can, that your prescription or your words mean anything too. So it's sort of part of that, cooperative that you're building. I mean, I think the pandemic, as anything, has taught us like this is really important for how we communicate why they should be taking what we're prescribing.
Right. So I want to refer the audience to the original paper in Arthritis and Rheumatism 2007 by Fred Wolf and Kaleb Michaud. The title is Resistance of Rheumatoid Arthritis Patients to Changing Therapy, Discordance Between Disease Activity and Patient Treatment Choices. You really should download it, and I'll put it in the show notes. It's a really good read. It'll tell you so much about the challenges you have as a clinician. And of course, this particular paper Kaleb's working on, it's coming soon to a PubMed listing near you. Kaleb, thank you so much for all your really important work in rheumatology, especially in the area of rheumatoid arthritis.
Thank you very much, Jack. It's nice to see you, and I'm glad to talk about this today.
Okay. Take care, everyone. Okay.